every 4 minutes. However, awareness about this critical brain condition is still low. Our aim today is to raise stroke awareness as it is the key to early detection, treatment, and recovery. So we will start with the basics first. Our esteemed panelists today will be discussing the signs, symptoms, treatment options, management, and the current state of public awareness in the field of stroke. Our first panel discussion is on charting the path to stroke awareness, strengthening symptom recognition, public health awareness, and management for stroke. Please give a huge round of applause to our distinguished panelists today. We have Dr. Jeyaraj Pandian, Professor of Neurology and Principal Dean, Christian Medical College, Ludhiana, and President-elect World Stroke Organization. Can we please have a round of applause for him? We have Dr. Deepak B. Saxena, Director, Indian Institute of Public Health, Gandhinagar. We have Dr. Sudhir Shah, Padma Shri Awardee, Professor and Head of Department, NHL Municipal Medical College, and Sardar Vallabhbhai Patel Institute of Medical Sciences and Research, Ahmedabad, Director of Neurosciences, Sterling Group of Hospitals, and Consultant Neurologist to His Excellency, the Governor of Gujarat. A round of applause, please. We have Dr. Anand Alurkar, President, Indian Stroke Association. We also will be joined shortly, he's on the way, by Dr. Nirmal Surya, Chairman Surya Neuro Center, Regional Vice President, World Federation Neuro-Rehabilitation, and President-elect Indian Stroke Association. Please join me in welcoming Dr. Kunal Bahrani, Director Neurology, Fortis Hospital, Faridabad. Along with sharing his views, Dr. Kunal will also be leading today's discussion as a session moderator. So over to you now, Dr. Kunal. Please have a huge round of applause for all our panelists. And
good morning, all. First of all, thank you, Voice of Healthcare, to invite me and to moderate this very important session because as we discussed, stroke is one of the most common cause of death and disability. More burden is there in our country. And till date, still we are lagging with the awareness of the stroke, more in the tier 2 and tier 3 cities. So this session, which we will just starting, it's more to create an awareness and to know about how we can tackle the stroke, what's something, how can we manage the strokes, preferably, particularly in tier 2 and 2 or 3 cities. So I welcome all the dignitaries in stage. To start the session, I would like to first address the question with Professor Sudhir Shah, sir. Sir, can you just please explain the audience what a stroke is, its types, and what are key signs and symptoms of a stroke, which one should know to diagnose a stroke, and what is the concept of golden hour care? So because we always talk about the golden hour, we are just not aware of the golden hour. Just you can highlight the key symptoms and signs and about the concept of golden hour. Sir.
Thank you. First of all, I must thank VOH and all the stakeholders, particularly Indian Stroke Association and others, and all of you for participating in this wonderful conceptual conference. I think it's the need of time. Without taking much time, just coming straight to your question, I think it's a long essay that you asked me, but I will try to summarize it. Stroke is what? It's suddenly stricken off. That is what the literal term is. The loss of part of body function due to of cerebral origin of vascular cause. So there is something wrong with the vessels of the brain, Either there is a blockage or there is a rupture of the blood vessel, and that produces loss of function of certain part of brain, and that produces loss of function of the body part. So if it is due to occlusion of a vessel, either due to clot or some fibrin or other thing, then it is called ischemic stroke. And if it is due to rupture of the brain vessel, it is called hemorrhagic stroke. And that could be arterial stroke or a venous stroke. So these are basically the subtypes. If the clot comes from the distant part of the body, like from heart or great artery, it is called embolic type of ischemic stroke. And if it is due to local occlusion of the vessel due to clot, that is called ischemic thrombotic vessel. So this is in short what are the different types of stroke. Now, as you mentioned, stroke is a terrible condition, but largely it is preventable, and it is very sad that right from patients to caregivers to some of the family physicians and doctors are not really aware of the exact symptoms and signs of stroke, and that is the reason why it is missed in early hours. Now, you mentioned about the golden hour. To give you the data, in every second during ongoing ischemic stroke, it is said that about 32,000 cells die irreversibly. If the ischemia is not treated and the blood circulation is not established, 32,000 cells die. On that count, every minute we lose 1.9 million cells. So in an hour, 1.2 billion cells are dead if we don't treat that ischemia. So this is why it is called golden hour. We have to save every second. Why hour? Every second we have to save. It is an earnest duty of all doctors. So what are the symptoms that we have to look for? If it is anterior circulation stroke, we have either loss of vision, or there is a weakness on one side of the body, or there is a sensory symptom, paresthesia, or loss of sensation on one side, or there is difficulty in speech, understanding, or communication difficulty, or even altered sensorium. If it is due to posterior circulation stroke, meaning vertebrovascular stroke, you have dysarthria, dysphagia, imbalance, or double vision, etc. But there is a slogan that we should remember. It's called "Be Fast." If we are in the community or in a setting of a home, if we find a person complaining of sudden loss of balance, that is B, or eye, that is eye symptom, loss of vision, double vision, or blurring of vision, BE, then F is facial asymmetry, there is drooping of face, or if you ask the patient to raise arm, both arms together, one of the arms would drift or go up and down, that is F. F is face, A is arm or leg, and S is speech. Ask the patient to utter some word or speak his name, etc. And there is some problem in name speaking or conversing, that is S. So be fast. Then T is time. Time is brain. Friends, every second 32,000 cells die, and we must not lose single second. And in the first 3 to 4 hours, if we give thrombolysis, the injection, the wonderful injection, then there are good chances of recovery and the whole circulation can be re-established in a good number of cases. That is the reason why we have to ship the patient immediately to the hospital, get a plain CT scan done, and treat with thrombolysis. Thank you so much. I hope I answered.
Yes, sir. Thank you, sir. Thank you, sir. I think it's a very simplified way of explaining stroke and about what are symptoms. So before further proceeding, I just welcome Dr. Nirmal Surya, sir, to be in a dash. Next question for Dr. Jeyaraj, sir. Sir, you and your institution is always pro for public awareness. We have already seen. So just we want to know, in your experience, what is the normal, like what is the most effective ways to educate people about the stroke awareness? And is there any tools or media means which are there where people get to know about the stroke and about the scientific basis of treatment of this stroke?
Yeah, I've been doing this public awareness campaign for almost more than 20 years in and around Ludhiana and Punjab. And so maybe at a regional level I'll begin and then I'll take it up at a national and a global level. So at a local level, what I have seen is starting from our own patients who are in the hospital, their relatives. So we try to have a once a week meeting for 15-20 minutes, call the relatives and the physios and nurses they will address, and if any of the neurologists, if they're free, they'll just address about risk factors. This is a very easy way of doing, or creating awareness so that at least the secondary prevention can be taken care, and even if they have new symptoms and signs, they'll rush to the hospital on time. And also, they can promote this to their relatives and friends. The second one, which is most effective, is the newspaper, awareness campaigns in any form in local vernacular language. English dailies, it's all good, but educated and people were very corporate setup, those are the people who read. But if you look at the circulation of the local vernacular language dailies, it's huge as compared to the English dailies. So that is one thing which we need to target. Social media is good, but again, if it is in the local language, for India, Hindi or whichever state language, then it is good. Now the way the internet is reached, the nook and corner of this country, so the social media, in terms of what type of messages, we have done a trial called Sprint India trial, where we sent behavioral messages, text messages, about 72, 7 videos and workbook. We tested these materials and whether really it can prevent another stroke, second stroke. So what we found was text messages are not effective. They get fed up. There is a fatigue. After 4th or 5th time when they receive the text message, they think, what is this? They may not read at all. So short videos, maybe I would say 30 seconds. In the trial, we had videos up to 2 minutes. And short videos, 30-second videos, that is probably very effective. This is based on the process evaluation that we did. We had a patient interview, relatives interview, healthcare professionals interview who participated in the trial. So this is one thing at a regional level. National level, we need to really look at not only the public but also the governments. From ISI's point of view, we had multiple efforts. I would say way back 2012 maybe, Ms. Rani Mukherjee was a celebrity. I was a stroke ambassador for 2 years. Then Mr. Sunil Gavaskar, and there was one commentator, I forgot the name, Harsha Bogle. So we had 3 celebrities as ambassadors. But at that moment there is some public awareness. We'll have media release and etc. But we could not sustain. Probably we need to have a program which is sustainable. We need to work with the government. There's another effort that from ISC we took was relevant video for the country. Probably Dr. Arvind would know, we worked with a professional media group. We prepared a video and we told the Ministry of Health and Family Welfare, it will be your video. That should be published or not telecast everywhere. But because of some bureaucracies, it got stuck. It is still with the Ministry of Health and Family Welfare. We have not succeeded. Like, for example, Tendulkar comes and talks about cancer. Just imagine somebody comes and talks about stroke in the TV. That will have a huge impact. So at global level, I would say from World Stroke Organization, experience the World Stroke Campaign. I've been involved from 2008 and I chaired the World Stroke Campaign Committee for 2 years. So what we have found is it should touch the grassroots level people. The message should be very clear, simple. Prevention should be the main focus. Of course, access to acute care, raising awareness about this golden hour, it is very, very crucial.
Rightly said, sir. So this is the era of reels. So now it's a high time we can always go for the short videos, reels of this stroke awareness. So one thing more, we always treat stroke patients not for their disability, motor disability, but also we treat the psychological aspect of the patient. So over to you, sir, only. How you think to navigate the psychological and emotional aspect of a patient undergoing this treatment stroke journey? Like in treating the stroke, how you navigate the emotional and psychological aspect of the patient?
Yeah. The first thing is a screening for these problems like anxiety, depression, and if they don't have motivation, it will affect the rehabilitation of the patient. So there is a self-checklist from World Stroke Organization and the roadmap, post-stroke discharge, the problems. So that's a simple checklist that can be used at a clinic level or a stroke clinic level, where we can ask questions. The nurses can do, or the person in the reception can just ask few questions, then we'll be able to quickly find out probably this patient may have depression. And for us as a busy practitioners, patient is there and we try to find out what is the active problem and then give it to the rehab people. Many times we neglect this depression and anxiety, which can really impair their functional status. So this is a simple step. And the second is there are, again, you have modalities, use of antidepressant, anti-anxiety medication to a tolerable level where they can participate in the rehab program. Counseling is important, and we should not forget the caregivers. Now, if it is a spouse who completely takes care of the husband, their burden also is very important. We need to take care of their mental health and the stressful life that they have. So we need to take care of the caregivers also.
Yes, thank you, sir. So now next question to Dr. Anand Alurkar, sir. Sir, we have already discussed the concept of golden hour, and we all know about the golden hour, how important it is. So, what do you think this concept of golden hour can do to patients who are there in the remote areas, and how they can get this better treatment when they are there in the remote areas? They know about the strokes, and how they can get a better treatment compared to this in the city, like in the tier 1 cities.
Yeah. So there are basically two types of treatments that are there in the golden hour, which impact the mortality and disability. One is the IV thrombolytic drug given intravenously, and second is a mechanical thrombectomy. As far as the IV thrombolytic drug is concerned, there is no reason why it should not be available even in the remotest rural areas.
Yes.
Fine. The problem will be there of the finances, but I don't think availability should be a problem. As far as giving the drug expertise is concerned, it does not require too much of rocket science. There are certain very well laid down guidelines which one has to follow. And we are seeing more and more physicians venturing into giving IV thrombolysis, which is an excellent thing actually. There are just few thousand neurologists in the country for a population of 1.44 crores, which is just not enough. If one says that only neurophysicians should be giving IV thrombolysis, it is just not logical in our country. So physicians, even general practitioners in the remotest areas are very well equipped to give IV thrombolysis. And therein comes the role of training and disseminating information, the various guidelines, etc., for giving IV thrombolysis, which we are doing as part of the bodies like Indian Stroke Association. As far as mechanical thrombectomy is concerned, it requires a much higher degree of expertise and technology and equipment, which is mostly absent in the rural areas if you talk only about rural areas. It is very well present in the urban areas and even in the semi-urban areas. Even in smaller towns, we are having now cath labs, and even many of our students who we train in neurointervention are going back to smaller towns and not getting restricted to bigger metros. But as far as rural areas goes, this is a big lacuna. So the problem is it's a slow process, but we are trying. We are training more and more people to take up this field of neurointervention, and we are encouraging them to go back to their hometowns, smaller towns, and take up this challenge.
Yes. Thank you, sir. So next question to Dr. Nirmal, Surya, sir. So we know prevention is one of the important aspects of stroke in stroke management. So over to you, sir. What steps can be taken to prevent the recurrence of stroke, first of all? And secondly, also, how it can be tailored with respect to gender. So is there is a difference in gender, like if we do for the stroke prevention part?
Right, Kunal. Thank you very much. I heard Sudhir bhai, I heard Jeyaraj and Anand has given. I think the best sort of a strategy should be the preventing the stroke. There's nothing better than preventing the stroke. And how do we do that? It's not very difficult. I think we need to have a protocol, sensitize the community, let everybody know that what risk factor you are carrying, because they will know from their parents, from their uncle, from their genetics, that these are the problems they have in their family. So they need to maintain a lifestyle. And we are talking about brain health for last 4-5 years through the World Brain Day. Very, very important to follow the brain health. That means you need to control your risk factors. And what are the risk factors which are the most common for the stroke is hypertension, diabetes, obesity, smoking, the lipids, high lipids, and of course sedentary life. So they need to do regular exercises. Even alcohol should be not very high, in the moderate amount. And every day, regular exercise is to be a mantra. India has always followed yoga, and you know that yogics has lived for 100 years. I think it may be worth, the government has done, Ramdev Baba has done a yeoman service, that he has been able to, reach out to each and every corner of the country. And now every person is sensitized to yoga. So it may be a good thing to do a Surya Namaskar or yoga, because many people will accept that. So that's very important. Now, second thing is, do you can say that, if somebody does all these, still he will not get a stroke? No, he still can get a stroke. So that's the challenge. So what are the other things we need to do? You need to have a regular periodic checkup. That means a person after the age of 40 years should have actual annual health checkup where his whole body risk factors are being checked. Now, it's possible that you are not aware, you are a vegetarian, your vitamin B12 is very low, and your homocysteine is very high, which could be a risk factor which you would not know. But if you do a regular checkup, you will come to know that, yes, this is something which needs to be controlled. So that's very, very important. Then, if suppose somebody says, I went once in a year, got my medical checkup done, that time everything was all right, and I still got attacked. So now what are the things there? There are many apps. Now you got an Apple Watch which check your heart rate. So there is a risk factor in the form of atrial fibrillation, arrhythmia. You can actually monitor your ECG, your pulse, your oxygenation. So there are many mobile apps which are available. And they are good to monitor you. It's not that you need to monitor every day, but they can at least help you to alarm you that your blood pressure is going high, or your pulse is getting low or high, or something is wrong with your breathing, oxygen at times fall. Similarly, another important factor is sleep apnea. Many of us do not know. We think that, the particularly obese people, and not necessarily obstructive sleep apnea can happen in anything. So anybody who is snoring very high and daytime excessive sleep should be a risk factor. So these are the things which can easily be controlled. And once you prevent this, probably you could prevent many of the strokes which could have happened.
Right, sir. So I think some part you have already covered. Last question to you. How can we best leverage that technological advancements? I think you have covered some aspect of that.
Correct. So, see, the technology has come big ways. And as I told you, mobile apps are going to be there for various reasons, not only for day-to-day health monitor, but also for many other things. And telemedicine is something which is going to be there. Now, tele-stroke, which is one part where people can treat the stroke through the tele experts. It's been going on all across the country. Telemedicine, so consultation. Tele-rehabilitation, so that's a big thing which is coming along with the family. So use of telemedicine has been very, very important. And using the AI And the advanced equipments would also help in long-term rehabilitation, particularly robot, visual rehabilitation. We'll come back to that in some time. So technology is there to take the help, but technology cannot make you walk. Technology cannot make you control your blood pressure, change your lifestyle. That you yourself has to do it.
Rightly said, sir. We have seen a change a lot after this post-COVID era. The upsurge in telestroke, tele-rehabilitation programs. So, last to you, sir, Dr. Deepak. As a leader in public health, what strategies do you believe public health institutions can implement to encourage the individuals to recognize stroke symptoms and to take a prompt action?
Yeah. Thank you very much, and thanks for inviting someone from public health. In the August panel of neurologists, it seems that we are odd men out, but it's good that this has been discussed, deliberated, although public health comes at last. But a couple of points I'd like to make. In this entire jigsaw puzzle, what I feel, stroke for some reasons have been camouflaged. We talk a lot about myocardial infarction, we talk a lot about diabetes. So there are certain points where associations like Indian Stroke Association can plug in. One, government is investing so much on comprehensive primary health care. There is a model whereby the CBAC forms day in and day out are filled up by ASHA, ANM, Anganwadi worker. So, we should leverage on what are the common points whereby the exact burden of the disease can be gathered. What I was looking at, when we look at the research, when we look at the landscape analysis of stroke, Pandian sir was mentioning, we do require a lot amount of research that needs to come up. We need to have those landscape analysis. We need to understand what are the factors with very specific reference to Indian context. That is what is required. Research institutes like Indian Institute of Public Health, Gandhinagar, or for that matter of fact, medical schools, they are very important. One of the important thing which I was listening to all this August audience, I came to know that, there is a, real shortage of neurologists or neurophysicians. I'm not sure whether there is any fellowship that is being offered in stroke whereby physicians can be trained, and they can be trained in numbers rather than, with e-courses coming up very fast. There are many courses on diabetes, there are many courses on hypertension, but looking at the, global burden of disease, number 2 disease, how many of this graduates or how many of this can actually come up very soon? So I was wondering, one, for sure, we need to invest more in research. Is there any possibility? Some of my colleagues have been doing non-laboratory based risk factors for cardiovascular disease. Is there a possibility in low resource setting where we can have non-laboratory based detection of stroke or cardiovascular disease that actually can be a risk factor? So we need to talk more with reference to first, primordial and primary care, and of course, the tertiary care. Thank you.
So, rightly point out, sir. So in continuation to it, over to you, sir, Dr. Sudhir, sir. So we know the risk factors for stroke. We run the clinics, we run the public awareness. Can you just address some of the primary risk factors for the stroke which one should know, and where one can modify those risk factors one should think of, and which should regularly check for those risk factors?
Yeah, I think my colleague Dr. Nirmal has addressed this question fairly well, and I think what we have to remember, the first and foremost risk factor is hypertension. About 40% of the strokes and even heart attacks are due to uncontrolled hypertension. So regular checking of blood pressure is most important. We have to educate people not to miss blood pressure, and if they have blood pressure, they should not stop the medication of their own. And those who have family history of hypertension, they must check it even regularly. And more important that whenever a patient goes to a doctor for any particular ailment, doctor's prime duty is to check the blood pressure of the patient. Even if he has gone for fever, blood pressure should be checked. This is one of the most important ways. In Canada, when I was visiting way back in 2012, I saw that the common salt bottles were removed from the restaurant. Just by adding extra salt in our diet, we increase our blood pressure by 10 millimeter. That increases the risk of stroke by 20%. So don't put extra salt, that is number one. Second is smoking. A single cigarette or bidi reduces our lifespan by 3 to 5 minutes, it is calculated. So if someone leaves tobacco or smoking at the age of 20 years age, then his or her lifespan increases by 9 years. These are data, not my studies. So it's very important to educate people. In fact, in contrary to what was discussed, I have tried to write books on educating people in Hindi, English, Gujarati and other languages for stroke and other all neurological ailments. And we have a massive drive on stroke in TV and newspapers we write, and we talk a lot of seminars. And I think it has worked. So that is another thing. Checking regularly for sugar every few months is also very important. People have wrong notions about blood pressure, diabetes, that I don't have headache, I don't have vertigo, I don't have weakness, why should I check? They should all be educated properly. And also the excess use of alcohol and other things should be removed. The government should take massive steps to remove all this drug abuse, particularly cocaine and all this, because this now it's like yeast, or it's a fungus that is spreading in the community. We should take all the steps. And similarly, obesity should be removed, stress should be removed, exercise, sedentary life should be removed, and exercise should be promoted. And now the new risk factor is pollution, sleep apnea, and after corona we have seen increased amount of coagulability in the blood. So all these things required to be properly addressed. So these are all the risk factors, and I wish all of us, all doctors, why not neurologists only? It should be physicians, general practitioners, and all other at healthcare work, industry. They should all participate, they should be properly trained, educated, and this knowledge should percolate into the community. Then and then only we in India would be able to prevent large number of strokes. And Dr. Nirmal said, stroke is largely a preventable disease, and time is brain. These two things we must remember as a most important message.
Thank you, sir.
Thank you.
So over to you, Dr. Anand, sir. So we initially discussed about the treatment part also and prevention part also. So just need to highlight what are most effective ways to ensure prompt medical intervention. So like we do interventions, we do give the treatment, but what are the most effective ways to ensure the prompt medical intervention to a patient?
Yeah. The word prompt is extremely important, as Dr. Sudhir Shah mentioned. Every second, every minute that the patient loses before the effective treatment is started, thousands and, if it is an hour, millions of neurons are already dead by the time the patient reaches medical care. Now, the first important thing I always tell in all my talks, whether it is to lay people or to even doctors and neurologists, that the diagnosis of stroke should be made at home. If you compare to myocardial infarction, it will be safe to say that 90% of people recognize a heart attack.
Yes.
It is so common. There is severe pain, precordial pain, chest pain, sweating, etc. And the patient is rushed to the hospital. People will do anything to rush the patient to the hospital. They will leave everything aside to rush the patient to the hospital when they think it is a heart attack. Now, this is unfortunately severely lacking as far as stroke is concerned. The diagnosis of stroke is not even made many times in the GP's chamber. The diagnosis of stroke is missed even in the casualty of big hospitals. Now, this is a very, very important lacuna. Now, any event which comes on suddenly, which affects one side of the body, and can be a stroke. It is as simple as that. Secondly, patients routinely neglect symptoms which are short-lasting. Patient has a TI for a few seconds to minutes, only slurring of speech. It is neglected. Not even patients, even doctors many times neglect TIs, saying that, oh, this was because of low BP. this was because of high BP, low sugar, high sugar, all sorts of excuses. You are overstressed, overworked, lack of sleep. That is why it happened. Just don't worry about it. It won't happen again. Now, this is at the level of doctors. At the level of patients, the problem is even more severe, but we can't blame the patients because it is probably our responsibility that we have not been able to educate the general population about the symptoms of stroke and the urgency required. So, recognition of symptoms and rushing the patient to a stroke-ready hospital. The common thing is a patient is taken to the GP's chamber. Wait for a few hours, couple of hours to be seen. Then whether the diagnosis stroke will be made or not, again is a big question mark. Second step is patient is sent to a diagnostic center for scan if a stroke is suspected. Very few patients reach a stroke-ready hospital. So the level of education should be such that when the family even thinks that this could be a stroke, the patient should be directly taken to a comprehensive stroke-ready hospital. And by a stroke-ready hospital, I mean that which has a 24/7 imaging, CT scan and MRI, neurophysician, neurosurgeon, intensive care, good intensive care, cath lab, and a good interventionist, trained interventionist. Now, it's not that these things are very rare. In most of our cities, there are multiple such stroke-ready centers or comprehensive stroke centers. So this is where the role of accreditation comes in. Not only accreditation, this accreditation should be probably broadcasted that these are the stroke-ready centers in this particular area. So prompt recognition of symptoms and even more prompt taking the patient to the right hospital will go a long way in reducing the mortality and disability.
Right. So next question to Dr. Nirmal Surya, sir. We all know he's a Regional Vice President, World Federation of Neuro-Rehabilitation. So, sir, with your vast experience in neuro-rehabilitation, can you just share your thoughts on the challenges and opportunities in neuro-rehabilitation and why you feel it's a very crucial role in the stroke recovery, this neuro-rehabilitation?
First of all, I just wanted to have a thought and put this point in everybody's mind is why we call stroke as stroke? Why we cannot name it as a brain attack? I mean, if we make it such that it is a brain attack, everybody get panic and go to the doctor. So I think stroke doesn't give a sort of a feeling to the people that it is something very serious. So we may really need to think that do we change the name stroke and bracket is a brain attack so that, you know, for the public, it become a very serious matter that yes, it is to be done so that they take proper precaution for early treatment. Now you had a stroke and patient has developed disability. You know that 1/3 patient recover completely, 1/3 remain with mild to moderate disability, and there are 1/3 people who remain with severe disability. So what best you can do? If you can't prevent a stroke and if you can't treat it in early hours where most of the disability can be reversed, the other best treatment remain is a neuro-rehabilitation, because rehabilitation is the only thing which can bring you back to the normal activity after a time. So what are the challenges? Challenges is that, you know, it is a very complex, brain is a complex matter. The same lesion in two patients in one patient can be completely having a minimum weakness, other patient may be a completely paralyzed. So you cannot identify that a lesion in the brain is in this area, this patient will not have disability or this patient. So that's the complexity of brain, because what sort of a compensation brain gives you, nobody knows. Then is challenge is multidisciplinary team. You do not have even the therapists in the rural area. So availability of a multidisciplinary team which have physiotherapy, speech therapy, occupational therapy, clinical psychologist, social worker, and orthotic are really luxury. They're only available at very few centers. So that's another challenge. Third challenge is the rural area particularly, where even the stroke is not treated. So what about the rehabilitation? Concept is not there. And I would also add to that is apathy from the neurologists. Once they have treated the acute care, they think that their job is done. And they just said, go and do the physiotherapy. I think that many of the neurologists need to understand right from the day one of the role of neuro-rehabilitation and involving the neuro-rehab team so that whatever deficit is required, and that way you will be able to, catch the cognitive aspect of the patient, emotion, the memory disturbance, the swallowing disturbance. In fact, we done a study and we found that out of 100 centers, 98 centers do not even assess swallowing on day one of the patient admission, when every patient has been put the Ryle's tube as soon as they get a stroke. So there is no evaluation which has been done. So this is very, very crucial. I think right on the day one or day two or day three, the neuro-rehab team should be included for the, now what we talk is acute rehabilitation or hyperacute rehabilitation, acute rehabilitation, early rehabilitation, subacute and chronic rehabilitation. So these have been divided. So that's important. Now, there are chances, the challenge, opportunity at brain is neuroplasticity. And though we say that 6 months and 1 year is the time limit where the maximum recovery in the brain can happen, we have seen the patient where even after 3 years and 5 years, patient has improved. And therefore, we just cannot blankly say that you lost 1 year, so you will not recover. We need to continue the rehabilitation. So that's the opportunity because brain is neuroplasticity. We got many new gadgets now. Now, the new kind of treatment, which include the robotic, the transmagnetic stimulation, direct current stimulation, various kind of robotic for hand, particularly suppose for the hand, for the shoulder, for the elbow, for the wrist, for the finger, and even same way for the leg, for the hip, for the knee, and for the ankle. So you can target that what sort of disability you are going to treat in this particular patient. So these are the opportunity which we have now. We got expert neuropsychologists who can treat the cognitive part. We also has got speech and swallowing assessment at very beginning. We got constraint-induced aphasia therapy like you have CIMT for hand functioning where the patient early speech recovery can happen. And of course, don't forget, India is doing a lot of work in brain-computer interface. Many of you may not be aware, but I'm on the panel for the BCI of Government of India. So I know that how the things has been done in India, and you will find that a lot of these new gadgets, particularly for visual agnosia, where the patient needs a visual rehabilitation, or the speech problem, these brain-computer interface for robotic hands, hand functioning, these are the something which is going to come. So neurologists need to be sensitized. They need to take role. As much as they have taken role in acute care, like thrombolysis, thrombectomy, in the neuro-rehabilitation. That's my take. Thank you.
Thank you, sir. My last question to Dr. Deepak Saxena. So we have seen lately implementing the PPP model. We have seen the telestroke. We have seen the hub and spoke model in the stroke management. So according to you, what different research initiatives can be undertaken to enhance the stroke management, and how can public health institutions contribute to improve the stroke care?
Thank you for this question. And again, these models have been very successful in various domains, say for Chiranjeevi Yojana or say for other initiatives that government has already implemented. My take on this is, there should be a win-win situation both for the private providers as well as for the government also, and also the insurance company. So my understanding is, there should be definitely some of the states should come forward and develop a public-private partnership type of stroke management units. And for sure, Gujarat can be one of those states. And what I have learned in the evening, Honorable Health Minister is going to come here. So for sure, as an association, Indian Stroke Association, one of the points that should be stressed to the Health Minister is let some models be developed beyond conventional Ayushman Bharat models, and if successful, they can be replicated elsewhere in the part of, in other states also. But yes, this is very important, very pertinent. And also, while listening, I was also thinking about that, there must be some sort of economic burden that is because of stroke. Some research should be taken up so that, it can be culminated in terms of pressurizing the government that, it's 40 years and less than 40 years who are now struggling with stroke. So more research avenues needs to be explored. Thank you very much.
Right, sir. I think it's the need of the hour now. So with this, I would like to end the session. And I thanks all the dignitaries for their valuable inputs. And the house is open for questions. If you have any questions, you can ask. And I think let's then end up the session. Thank you.
Thank you so much, panelists, for that enlightening discussion. So please, I request you all to please stay on the stage for the felicitation. I would like to invite Dr. Kunal to please felicitate all his co-panelists. May I have the certificates? Dr. Deepak Saxena. Dr. Nirmal Surya. Please, a huge round of applause for all our panelists. Dr. Sudhir Shah. Dr. Anand Alurkar. May I please invite Dr. Naveen Nishal now to felicitate Dr. Kunal. I request all of you to please come forward for a group picture.